Epidemiology stems from the Greek words epi, meaning on or upon, demos, meaning people, and logos, meaning the study of. Epidemiology is the science that studies the patterns, causes, and effects of health and disease conditions in defined populations. Epidemiologists are often referred to as disease detectives. As scientists, they must figure out the 5 W's of an outbreak investigation, or in this case, a foodborne disease outbreak investigation. The 5 W's are who, the person, what, the health event, where, the place, when, the time, and why, how, the causes, risk factors, and transmission. During an investigation, the epidemiologist will generate and test hypotheses to figure out the cause of the outbreak. An epidemiologist must identify the cause of disease, understand and determine factors that increase a person's risk for developing the disease, and describe how the disease was transmitted. They must also recommend interventions and ensure successful implementation of control and prevention measures to reduce future occurrences of the disease. Epidemiologists are part of the four-legged stool that uses these tools to solve outbreaks. The four-legged stool consists of epidemiologists, environmental health specialists, public health laboratorians, and other ancillary staff, such as public health clinicians and communications staff. These groups work together to detect, respond to, and prevent foodborne disease outbreaks. The duties of an epidemiologist include routine disease surveillance, case interviews, data collection, specimen and sample collection, data analysis, disease education, and risk communication. In order to identify new cases of disease, epidemiologists conduct disease surveillance. The goals of surveillance activities include defining the magnitude and the burden of disease in the community, monitoring trends, measuring the effectiveness of control practices, attributing disease to specific food vehicles, providing a platform for applied research, and disseminating new information for education and awareness. The term foodborne disease surveillance is often used to describe constant monitoring in a population for any enteric or gastrointestinal disease. A primary function of foodborne disease surveillance is to detect illnesses that could have been caused by food. Surveillance is also used to identify clusters of possible foodborne disease. Foodborne disease surveillance and outbreak investigation activities have long remained among the most productive public health practices to prevent illness. These activities have resulted in the prevention of countless cases of disease through the recall of hundreds of millions of pounds of contaminated products. Such tireless work has also prompted changes in food production and delivery systems that have resulted in a safer food supply and reduction of new cases of foodborne disease. In order to monitor foodborne disease trends, cases of illness are reported to the Public Health Agency. Each state has authority to define conditions of public health importance, also referred to as state reportable diseases. The list of reportable diseases varies among states and over time. Most foodborne diseases are reportable. The Centers for Disease Control and Prevention, or CDC, designate certain conditions as nationally notifiable. The National Notifiable Diseases Surveillance System is a nationwide collaboration that enables all levels of public health to share notifiable disease-related information. CDC requests that states notify them when a person has a disease that meets the national case definition, but it is voluntary that notifiable disease cases are shared with CDC. The list of nationally notifiable diseases are reviewed and modified annually, and every nationally notifiable disease is not necessarily reportable in each state. Pathogen-specific surveillance occurs when healthcare providers and laboratorians report individual cases of reportable diseases, such as Salmonella or E. coli 0157:H7, when these are identified in specimens from patients. This practice first began in 1912 for Salmonella typhi, the causative agent of typhoid fever, and was extended to all Salmonella species in 1942, making it one of the oldest pathogen-specific surveillance programs. Pathogen-specific surveillance also allows for the detection of disease clusters. After additional analysis performed by state public health laboratories or CDC, linkages may be seen between widespread disease clusters. This type of surveillance is relatively slow and works only for diseases detected by routine laboratory testing. Receiving and responding to reports of disease from individuals in the community has been an essential function of public health agencies since their inception. Complaints of illness reported by consumers associated with specific events or food establishments generally are referred to the agency responsible for licensing the establishment. Consumer complaints lead to the identification of most localized foodborne disease outbreaks and help epidemiologists detect outbreaks that are caused by pathogens that are usually not reportable, such as norovirus. Complaint systems do not depend on ill persons seeking medical attention. Some health departments have complaint forms that can be submitted electronically, while others receive complaints over the phone. Complaints are responsible for the detection of approximately 75% of foodborne disease outbreaks reported each year. Syndromic surveillance is a relatively new concept. It was developed in the 1990s and expanded after the 2001 postal system anthrax attacks in an attempt to improve bioterrorism preparedness. Syndromic surveillance typically relies on automated extraction of health information from preclinical, clinical pre-diagnostic, and post-diagnostic sources. Calls to poison control centers and chief complaints of individuals who go to hospital emergency rooms and urgent care centers yield symptom data. This data can be used to group individuals by syndromes. Certain symptoms may alert public health personnel to foodborne diseases and conditions, such as botulism and hemolytic uremic syndrome. Active surveillance involves employing staff members to regularly contact healthcare providers or the population to seek information about health conditions. Active surveillance provides the most accurate and timely information, but it is also time-consuming. Active surveillance is also referred to as case finding and is often used to find cases of foodborne disease during outbreaks. Epidemiologists monitor pathogen-specific surveillance systems for new cases of foodborne disease. When a local health department is notified of a positive laboratory result for a potential foodborne disease, an epidemiologist or designee is tasked with collecting the 5 W's by conducting a case interview. An epidemiologist usually calls the patient to ask about recent exposures that may have caused illness, such as food they have consumed, travel history, water exposure, and contact with animals or other ill individuals with similar symptoms. The information that is collected from the interview is usually entered into a case management database where the epidemiologist looks for common exposures among multiple people. Epidemiologists interview complainants to gather necessary information and determine if a food item was the source of illness. In addition to food exposures, epidemiologists will ask complainants about animal exposure, recreational water exposures, and settings where person-to-person transmission may have occurred. If complaints are received from several persons who have eaten the same food or have eaten at the same restaurant, a food item is the suspected source of illness. The epidemiologist will then initiate a foodborne disease outbreak investigation. If an epidemiologist uses a syndromic surveillance system, they evaluate alerts triggered by the system. Some alerts may indicate a potential foodborne illness outbreak. These alerts are investigated further to determine if they are associated with the reported exposure. During routine review of surveillance data, common trends among patients can be identified. When an abnormal number of cases of the same disease has been identified in a given time period, it's called a cluster. This unusually high incidence of a particular disease warrants further investigation. CDC defines a foodborne disease outbreak as an incident in which 2 or more persons experience a similar illness resulting from the ingestion of a common food. Foodborne disease outbreaks can be detected in various ways. One example is when multiple people become ill from food they ate while attending the same event, such as a wedding or potluck. Upon notification of this type of outbreak, an epidemiologist will conduct active surveillance, or case finding. During active surveillance, calls are usually made to all of the event attendees to determine if they are ill or well. In contrast to passive surveillance, where cases of illnesses are reported to the health department, epidemiologists actively look for cases that have not yet been reported or would otherwise have not been reported. To classify exposed persons and non-exposed persons during an outbreak investigation, epidemiologists develop a working case definition. A case definition is a standard set of criteria used to classify persons as being associated with a particular outbreak. These also help to reduce biases and misclassification during the outbreak investigation. A case definition includes criteria for person, place, time, and clinical features that are specific to the outbreak under investigation. Case definitions are sometimes tricky to develop. They need to be specific enough to identify true cases of disease, but also need to be broad and sensitive enough to identify most, if not all, cases. As a result, the case definition may change during an outbreak investigation to narrow or broaden the focus of the investigation as needed. An example case definition might begin generally, such as a person who consumed food items served at elementary school A between November 1 and November 8 and reported diarrhea within 1 to 3 days after consumption. To further classify cases in an outbreak, epidemiologists identify primary and secondary cases. A primary case is a person reported as having direct exposure to the suspected source of illness, such as a specific food item. A secondary case is a person with no reported exposure to the suspected source of illness, but who was judged to have acquired the illness from an ill person who was exposed to the food item. In certain study designs, epidemiologists identify controls or individuals without the illness that serve as a comparison group. It is important to develop a hypothesis when investigating a foodborne disease outbreak. A hypothesis is an educated guess that serves as an explanation for the occurrence of disease. Epidemiologists use available information to describe the affected individuals and determine the cause of the outbreak. Hypothesis generation is important because it directs immediate control measures, narrows the focus of subsequent studies, and determines the need to involve others in the investigation. The hypothesis includes the likely causative agent, people at risk, mode of transmission, vehicle, and the period of interest. An example of a working hypothesis is the outbreak is due to a bacterium that caused diarrhea and was spread during the first week of November by a food commonly consumed by children. During outbreak investigations or routine surveillance activities, epidemiologists interview ill individuals who are infected with the same pathogen using a hypothesis-generating questionnaire. These questionnaires collect a standard set of information about food and other exposures for all cases. By collecting the same information across many different areas, data analysis is more efficient and the time it takes to pinpoint the source of an illness can be reduced. An epidemiologist should keep an open mind during the beginning stages of an outbreak investigation because the source of illness could be something other than food. When a cluster is detected from laboratory data or interviews, an epidemiologist may re-interview the individuals with a more in-depth questionnaire. The epidemiologist can ask the public health laboratory to conduct additional analysis of available specimens and samples. These tests can help determine if the same pathogen strain has infected the known cases. Epidemiologists are tasked with collecting data, choosing a study design, and analyzing the data accordingly. Case control studies and cohort studies are often used to determine whether there is an association between exposure to a foodborne pathogen and development of a disease. Epidemiologists carry out a cohort study design when individuals involved in the incident are easily identifiable, accessible, and the exposure is rare. A cohort study begins with a group of exposed individuals and compares them to a group of non-exposed individuals. To determine if there is an association between the exposure and disease, epidemiologists calculate the relative risk. The relative risk is defined as the risk of disease in the exposed group divided by the risk of disease in the non-exposed group. This study design is generally a good choice when investigating an outbreak in a relatively small but well-defined source population, such as a wedding or potluck dinner. A cohort study would be used for the outbreak in elementary school A because the group of students ate the same food during a defined period of time. A second type of study design, often used by epidemiologists, is a case control study. This study is used when cases of disease appear over time and cannot be tied to a specific source. It can also be used when identifying an entire group of exposed individuals would be costly and difficult. A case control study begins with individuals with the same disease or cases and compares them to people without the disease or controls. Cases and controls are then assessed for exposure to likely sources of the pathogen. To determine if there is an association between a disease and a specific exposure, epidemiologists calculate an odds ratio. An odds ratio is defined as the odds that a case was exposed divided by the odds that a control was exposed. An example of a real-world case control study took place during 2002 to 2004 when the Foodborne Diseases Active Surveillance Network conducted a population-based study of sporadic salmonellosis among infants under 1 year of age in 8 states. Cases were identified via active laboratory-based surveillance, and healthy controls were frequency matched by age and identified through birth registries or published birth announcements. Choosing controls is often a challenge for an epidemiologist. Controls need to be chosen from the same population as cases and should be similar to cases in some aspects, except that they may or may not have been exposed, and they aren't sick. Epidemiologists determine whether a foodborne disease is associated with a certain food exposure by using data from cohort or case control studies. After conducting interviews, epidemiologists calculate the attack rate, also referred to as the incidence rate, for each exposure being assessed. Food-specific attack rates help point to a suspected food within a meal and can support observations and conclusions on food handling that contributed to the outbreak. In addition to calculating the attack rate, epidemiologists graph an epidemic curve, commonly referred to as an epicurve. An epicurve is a graph that depicts time distribution of onset of initial symptoms for cases that are associated with the outbreak. The unit of time depends on the interval covered by the outbreak and varies by disease etiology. For example, a scale of hours or days would be used for Staphylococcus aureus toxins or salmonellosis, but a scale of days or weeks would be used for hepatitis A, because there's more time between the exposure and onset of symptoms. The time between exposure and onset of symptoms is called the incubation period. The time interval should be on the x-axis. Epicurves help determine if the outbreak originated from a common source, such as a food item, or if it's a person-to-person. The epicurve can also assist in determining the time period of exposure if the pathogen is known. An epicurve may display the mode of transmission of an outbreak. Cases that had an exposure to the same source over a brief period of time will usually form a point source epicurve. The number of cases may rise rapidly to a peak and fall off gradually. The majority of cases in a point source epicurve are within one incubation period. Cases that had exposure to the same source over a period of days, weeks, or longer will usually form a continuous common source epicurve. The curve usually rises gradually and may plateau, or the downslope of the curve may be sharp if the common source is identified and removed. Cases that had an exposure to another person with the same illness will usually form a propagated epicurve. The curve includes a series of progressively taller peaks until the group of susceptible persons is exhausted or control measures are implemented. Epidemiologists work with public health clinicians to collect clinical specimens from ill individuals during an outbreak investigation. These specimens are sent to the public health laboratory for confirmatory analysis. Likewise, epidemiologists coordinate with environmental health specialists to collect suspected food samples for analysis. Once the laboratory has identified a pathogen in a clinical specimen or a food sample, the results are sent back to the health department for further interpretation by an epidemiologist or a clinician. If a food establishment has been identified as the source of an outbreak, an epidemiologist will often accompany an environmental health specialist along with the appropriate regulatory partner on an environmental assessment of the implicated food facility. Successful communication between epidemiologists, environmental health specialists, public health laboratorians, and nurses, regulatory partners, and industry partners help to solve the outbreak and prevent additional illnesses from occurring. In addition to investigating outbreaks and conducting interviews, epidemiologists provide information to members of the community. They counsel patients on disease transmission, educate on symptoms and how to seek medical attention, and provide information on recalled products and proper disposal techniques. These types of communication, along with other pertinent information, helps to prevent the spread of foodborne illness in the community. Foodborne disease outbreaks can present a serious public health threat. Epidemiologists work with public information officers to let the public know about current outbreaks and food recalls. When an outbreak investigation has concluded, epidemiologists write up a final outbreak report that details the investigation procedures as discussed in this video. Depending on the laws in your state, the report can be shared with regulatory agency partners, industry partners, implicated food establishments, and those impacted by the outbreak. Enteric foodborne disease outbreaks should be entered into the National Outbreak Reporting System. This system tracks enteric foodborne diseases and allows CDC to aggregate data and identify trends over time. Results from foodborne disease outbreak investigations are often used to improve upon current practices in public health and industry, strengthen regulations enforced by regulatory agencies, and educate the consumers about food products. The next video will introduce how public health laboratorians assist with investigating foodborne disease outbreaks in the United States.